think worldwide and in the pain field, the major impact of the Chronic Pain and Fatigue Research Center has been almost inventing this term centralized pain and getting clinicians to understand that a lot of pain is in fact coming from the brain.
The condition that we've historically studied the most is fibromyalgia. And some of the research that we've found has shown that the problem that may be happening in certain fibromyalgia patients is that there's an alteration in either how different areas of the brain are connected with each other, or there's an imbalance in the neurochemistry, which then causes an imbalance in the functioning of the brain. So brain areas that normally are involved in processing pain become hyperactive. The person might be perceiving that they have more pain or having more pain than they really should have.
Until our group and others did brain imaging in conditions like fibromyalgia, the view in the medical field was that this wasn't a real disease. There was really nothing wrong with these people. The entire medical field has come a long way because of the research that our group and others have done to show that these are very real problems.
What our center is now really focused on is taking those revolutionary findings in terms of how the brain is affecting pain in a chronic pain patient and translating them into a very simple paper and pencil method of determining what kind of patient you have sitting in front of you in your office. What has been really transformative for us is to ask not how much pain, but where the pain is. And when we do that, when we ask people to use, say, a body map and designate on that where they have pain throughout their body, we find that some of the most interesting relationships in terms of response to treatment, response to surgery, and outcomes are related to how widespread that pain is. But also whether or not they have these other comorbid symptoms like fatigue, difficulty sleeping, difficulty concentrating, symptoms of depression. When we take all of that and we put it together into one sort of construct, we find out that that's actually a very useful way of phenotyping patients. While this is, in some ways, a very simple idea, it hasn't been widely applied in the field of chronic pain research.
Quantitative sensory testing is something we do fairly often at the center. It's QST for short, and it can basically be defined as techniques that are used to study the relationship between a stimulus, something that exists in the external world, and the sensation that's produced by that stimulus. Most of the time at the center, we're interested in looking at differences between people who have chronic pain and healthy controls. And so we do things like apply a pressure stimulus to a person's thumb and have them rate the intensity of that stimulus. The amount of pressure that we apply is very well controlled, and we use numeric rating scales so that we can get a nice quantifiable measure of the person's perceived pain. And what we'll often find with that is even in conditions, say like temporomandibular disorder or chronic pelvic pain, where people don't necessarily have pain in the hands or the thumbs, even if we test their pain sensitivity there, they have widespread pain sensitivity. So they may rate the stimulus as being more intense, more painful, more unpleasant than a healthy individual.
Once you identify that someone's pain is partly or entirely coming from the brain, that has pretty profound treatment implications, because it turns out that the drug and the non-drug therapies that work best for pain that is coming from damage or inflammation in some part of the body, those treatments like opioids or surgical procedures or nerve blocks don't work if someone's pain is in fact coming from the brain or the central nervous system.